guys, welcome to another episode of Modifiers Live. We are here on a Tuesday. I'm really excited for Modifier Tuesday. I personally, as you know, I'm really close to my guest that I have on the show today. So I want to welcome to the show Ms. Christine Hall. Hi, Christine.
Hi, everybody. Hey, Jennifer. Great to be here today.
I am so excited that you're here with me today. It's so exciting to have you on the show, especially about modifiers. I know you and I both have had our discussion on modifiers, but before we get into it, let's catch up a little bit. I know I just saw you at, of course, the Healthcare Advocate Summit in New Orleans. Did you have a good time?
Amazing. It was absolutely amazing. We did something different this time. We went outside of New Orleans and we did a swamp buggy ride or an airboat ride in the bayou in the swamps. And
the bayou. Oh my goodness.
It was so much fun.
Okay. So my friend Autumn, who you met, who is pharmacy tech, my friend who I brought with me to the conference, we drove down, right? And we went to do a road trip. So just the girls. And so that was my first time driving into New Orleans. I've always flown before.
Wow.
So got to like drive, see some of that bayou stuff. And it was just the coolest. I'm like, one of my favorite movies was actually The Pelican Brief. I don't know if you ever saw that.
Yes, absolutely.
When I was a kid, that was like my favorite movie and really got me into the John Grisham novels and obsessed with that. And The Rainmaker, another one of my favorite ones.
Yep.
And so New Orleans, it was like, I was like reliving that movie, like, oh, she was right there and that's where she was. And it was just like, it was just so much fun. And like, I feel like it was a great experience. And then of course, next year we're going to be in Vegas for Healthcare Advocate Summit. So yay. And then, so everyone knows, Christine and I, we love to collaborate all the time. And so we are going to be in Charleston on December 7th and 8th for the NAMUS conference, 15th annual. Exciting stuff, right?
I cannot wait. It's going to be an amazing conference.
No, 100%.
No one wants to miss it.
Absolutely not. It's going to be fabulous. And you and I both are about integrity, ethics, compliance, right? So it makes sense for us to both talk about revenue integrity. It's a big deal. And part of revenue integrity is understanding modifiers. So today, let's talk about some of the unused and misapplied modifiers, the telehealth modifiers. So
well, I love telehealth, Jennifer. So I've had the privilege of working with the Southeastern Telehealth Resource Center for a long time, and huge advocate for telehealth in providers' offices. As you know, during COVID, the barn doors kind of got blew open on what services could be provided via telehealth, especially from a CMS perspective, because CMS was always really reserved in allowing telehealth services to happen in a patient's home or, in a casual setting. So, of course, there was a need and we were allowed to open up telehealth, and a lot of pros, some cons too, right? We need some guidance in the business of medicine, definitely. But I do love that we've got some specific modifiers that we use not only to assist us in payment, but we use modifiers sometimes to data mine information, like how many people are really using telehealth? Are we using audio only? Do we need to keep it? We don't really know until we start looking at how those services are reported so we can analyze its use.
Absolutely. So I remember many moons ago, back in 2020, right, when we went down this new road of telehealth. Back in the day, early pandemic, right? So I was working then as a consultant, but also as a full-time coder for my local hospital. I was still there, making the money, while I was building my consultant business. And I remember I was just working just to code. And I was like, I don't want to touch telehealth. Just keep the surgery. But then it's like crept into my surgical practices. And I'm like, here we go. I've got to figure this out. So we had the spreadsheets they would send us, like, here is your GT, use it for these payers. Here is your 95, use it for these payers. Place of service 02, place of service 11. It was like all the time. And even now we're still seeing a lot of questions and trying to keep up to date. And it's hard for a lot of people because they're trying to maneuver so many other things in the practice that keeping track of this is what's a good, like, I guess, way that you can explain a good way to keep organized.
So the best way I can explain it is coding is a science. We read the documentation and we assign the correct codes.
Mhm.
If there is a special circumstance that needs to be described in documentation, we assign a modifier. So again, very methodical in coding purposes. But then when we cross over into the billing world, billing is an art
Yes.
because so many payers have different requirements.
Mhm.
Not everyone follows the same structure that's in place. So Medicare has its structure. Medicaid, depending upon your state, has its structure. You've got all your commercial payers, each one of them, whether it's an association like Blue Cross and Blue Shield or Aetna, or it's a global organization or national organization like United Healthcare or Humana. Their rules, their guidances, they change depending upon what their specific policies are. So that was indeed the problem, Jennifer. In the beginning of the public health emergency, you had United Healthcare that was saying, use place of service O2. And you had Medicare that was saying, no, use the place of service that you would normally see the patient. And what it all boiled down to was we wanted to make sure we were getting that payment parity as if we were seeing the patients in the office face to face. And so
Mhm.
each payer kind of had to adjust the way that their benefits were based on that new requirement that we were seeing.
Yes, and I think one of the other things that really confused people, and I'm not gonna lie, I was one of them for a little bit because it wasn't something I was used to previously. I didn't really touch telehealth. None of us really did because it had its own unique place in
Mhm.
healthcare prior to the pandemic. And
Well, it's its
so
own benefit under Medicare.
yeah, it was very unique, and it wasn't used in every circumstance. You had to meet this criteria, which of course we will eventually get back to in some
Mhm.
ways, as we know. But the synchronous versus asynchronous, I think those terms people didn't really like. Those aren't terms we use every day. So, like, get out your
Well,
dictionary. What do these words mean?
synchronous is what we're doing right now.
Yep.
It's you and me. I see you. I see that beautiful painting in the background that I'm
Yeah.
absolutely in love with.
We'll talk about
Um,
that in a minute.
that's right. And you see me in that really
Mhm,
cool new skull that I got that has all the anatomical parts all mapped for it. So
mhm.
we are synchronous right now. It's
Yes.
happening in real time. There's no pre-recording. This is absolutely happening right now. So if I you can't edit that out. We're
Mhm.
live. So synchronous. Asynchronous is the different ways that we communicate: text messages, emails, um, anything that is pre-recorded and then able to be viewed at a later date. So on demand, those are all asynchronous. So they're not happening right now. When you get that text message and or you send a text message to somebody and the waiting starts and you're
Mhm. Did
just
they read it?
waiting and
Did they read
waiting.
it?
Yeah, or you send that email out to Christine and 3 days later she answers you.
Been there,
Um,
yeah,
trying to be better, but those are not in real time.
right.
There's a delay there. So it was making us understand that telehealth reimbursement needed to be in real time, happening
Mhm.
right now, immediate, and not that it was on demand or email or text where we don't control the back and forth conversation.
Exactly, and, this may or may not compute to those out there watching, but, like, when I think of the word when there is an "a" on the beginning of a word, I think of it, like,
Mhm.
without, so, like, asymptomatic, if you're asymptomatic, you're not with symptoms, so you're
Right.
not with that live virus or whatever it is. You are, you have it maybe, but it's not showing itself, right? So, like, in general, that's how I kind of think about it, and I have to equate it to something I already know. And so
Yeah.
that's kind of how it brings to my mind. I connect the two that way. That may help some of you to think of it that way. When we think about that piece, that really helps, right? And it is more beneficial for the physician to see and hear the patient. We know there are some services that really should not be performed via telehealth. And I am a podiatry consultant. I am the consulting editor for Podiatry Codify newsletter. And so I work with AAPC on that newsletter. And I am often, promoting that idea that we really should focus on which specialties really need to be seen in person. Um, and how
Well,
would you like to say about podiatrists? I mean, talk
well, and
about
here's my thought, Jennifer. It's not necessarily what specialty should or shouldn't. It comes down to the condition.
yeah.
So from a podiatry perspective, like I know that podiatrists could probably look down at an image of a foot, or if we tilted our camera to the foot, the podiatrist could see that yellowing or dryness of the nail bed is indicative of a fungal type of infection. But if we're talking about maybe range of motion in a foot, or we're talking about um, fingernails, toenails that need to be trimmed because it's a diabetic patient and we don't want them to hurt themselves, those are physical types of services that need to be reported in person. So I would never expect that we would see a procedure that would be reported telehealth. And the services, again, it needs to be a service where we could actually diagnose and treat that condition visually without having to put our hands on the patient. So more of a condition rather than a specialty.
100%. That's why I'm glad you brought that out, because that's what my next thought was, is thinking about it by the patient level. What does that patient need versus this patient?
You could never do a telephone visit for podiatry. I mean, I can't even think of what world that would be unless it was a chronic condition where, you called the doctor and you said, hey, I've got that funky toe jam thing happening again. Should I use this cream? But now that we've got so many other service codes besides evaluation and management, we have the virtual check-ins that we can also reimburse. We have the online E&Ms that we could report and get reimbursed. It often becomes, again, part of that art of knowing which particular code is most supported in that documentation. Which one is the right code we should be reporting?
100%. I think about some of the challenges that we've seen, and we want telehealth to continue. We want different facilities, different types of services that should continue, like mental health. So let's jump to mental health for a minute, like behavioral health. What are some of the modifiers that we know are unique to them?
So a couple of the new modifiers that were added specifically for telemental health, one of them is our FS modifier. So the F is in Frank, S is in Sam modifier. And that's when we have a telehealth service that we need to report today as audio only. Oh, excuse me, it's FR. So FR modifier. There are a lot of times that mental health can be provided to a patient audio only on a telephone call. Again, we have found that the audio video seems to work best because we're able to gauge someone's body language, their facial expressions, things that are nonverbal, we're able to capture during those audio video. But there are people that live in certain areas. I shared with you that my husband left a little while ago on a trip to West Virginia. That is one of the areas in the country that is still lacking in bandwidth. And it makes it difficult to have those audio video communication visits because they don't have access to cellular service the way that we do. That they might have to rely on an audio only. And I'd rather a patient get mental health treatment than to not. So if that is the only way that they can get it, the modifier is great because it allows us to data mine and collect information that modality is prevalent in a particular geographic area or overall population that we're seeing. So yeah, that's one of the big ones that we see regarding telemental health.
Yes, and I agree. I mean, not one of us can say we haven't been affected mentally and emotionally by what we went through these last few years. And some of us were suffering before then from other things, right? I know I was going through some mental issues and emotional issues from a previous employer that I was with prior to the pandemic. And so those residual effects got worse for me personally. I'm not ashamed to say it. I
Yeah.
have done podcasts on mental health because it was my therapy to get out my feelings and to get out what I went through from an employment standpoint. So it's so many of us are affected, and children were affected. So,
Yes. We had a
sometimes,
lot of
yeah.
um, healthcare providers who really were affected by COVID. When
Mhm.
you talk
COVID.
about children, all of those your family members that were hospitalized for COVID, and we weren't allowed to visit them in the hospital, and that restriction affected people, especially when it resulted in a loss that you never had that closure there with those patients. So we saw so much during that time. It was very traumatizing to, I think everybody was impacted in one way or another. People lost their businesses, their livelihoods. It affected marriages. It affected the economy, in the housing. It affected every area of our lives. And so I don't think any one person can say that it didn't affect them.
Mhm.
And I think Congress saw that. Congress immediately jumped and they made changes in the Consolidated Appropriations Act of 2022 saying, whoa, we need to expand access to mental health services, whether it's telehealth, telephone, in person. Let's just really expand these benefits out to as many people as we possibly can.
Absolutely. And it's not going to be easy, guys. It's going to be tough to kind of go from back and forth. We've had some updates, and we're not here to talk about telehealth in general, like the whole gamut, because we only have a few minutes left on this broadcast today. But we will encourage you to visit your Mac websites to get some of those criteria. Novitas is my favorite. Glad it's my Mac because I love them. They all have the great modifier tips on there. So check your Mac carrier, see what they say about it. Medicare has some great telehealth tools on their website. And again, for your very specific commercial carriers and some of those ones that unique payers that have their own take on things, I've always been a proponent of spreadsheets, shared spreadsheets, or whatever
Mhm.
portals you can create. Any way you can create tools for your team that everyone has access to, ShareFile, or if you use SharePoint, whatever you use in your practices, just make sure everyone has access and it's updated regularly. Someone's job to do that. Maybe it's your compliance officer that is going to be the one that manages and makes sure that that stuff gets taken care of. Both Christine and I, we do compliance assessments for many organizations. And so we are all about making sure that those things are done. Your coding and billing teams, they need resources unique to them. Your physicians need resources unique to them. And everyone in the office needs to know how it's affecting the patient, how it's affecting their job, and how it's affecting the practice.
Well, you've heard me say this about a million times, Kimberly. I mean, Jennifer. I said it to Kimberly last night. The only thing that we can really count on in this industry is change,
Absolutely.
and change is the constant. So, like, I'm working on a presentation right now, just highlighting the issues that are in the proposal, and in hopes that we might see some of these changes in the final rule for Medicare, for the Medicare physician's fee schedule. Also, we have all of the new ICD-10 codes, 395 new ICD-10 codes that will become effective in 11 days. We recently, in the last week, CPT gave some of the publishing like AAPC, AHIMA, those new codes that they're proposing out there for the 2024 year. So we're going to start seeing more education on those changes there. Again, that it's the only constant.
Yeah.
So we need to make sure that we're up to date. Now, I'm going to give a little plug. You're doing your modifier tour, right?
I
And
am.
I know that you're going to be talking about telehealth modifiers.
Yes.
And again, I want to remind our listeners that these modifiers, a lot of the modifiers are implemented so that we can data mine the use of a particular service through a modality like audio only. And it's going to take us using those modifiers correctly to affect future changes in these services that we perform.
Absolutely. And so you have to stay up to date. So at the boot camp, if you go to the modifier boot camp, the QR code there, you can see the actual full schedule and you can pick the date you want. There's going to be obviously virtual for every location. So you can attend from anywhere in the country, whatever date you want. But we do strongly encourage you to come out in person because that's where you're going to get those unique things you can't get virtually. you're going to get that one-on-one communication with myself and the others there that can really kind of, I think, help you. We're going to give you unique challenges and solutions for your area. Because when we go to Tampa, when we go to Dallas, when we go to St. Louis, we're going to go to California, we're going to Denver, like wherever we go, we're going to pick unique situations to your state, because it's not about just everyone. It's about you, what you uniquely deal with. And we're going to give you technology tips. One of the services we offer at Healthcare Inspired is EMR optimization. And one of the things I think we're failing at is optimize our EMRs for modifiers. There's a lot of unique ways that we can automate tasks for our modifiers. So you can tell your system, if this occurs, do this, or if this happens, make sure this doesn't go out. So that way your physicians can still do their job if they're responsible for picking the codes like you want them to, right? You want them to be in control of their services. That's great, but make sure your system catches things that should not happen. You can set that up ahead of time. It makes maybe it makes maybe a couple weeks of downtime where you have to have somebody that's their job for a couple weeks to get the system set up. But once it's done, it's done. And then all you have to do is update it.
Well, I want to remind folks again that even though you may have the best EMR and EMR optimization, it's still important to remember that the use of modifiers should never be to get something paid.
Absolutely.
It should be that the modifier is supported. And we are seeing a lot of audits, whether it's the TPE audit on the MAC level that is maybe auditing something like mental health services, or they're auditing rehab services. When a modifier is used for any of those services, you're opening up the door to have the use of the modifier included in that audit. So remember that whether or not that's the reason, the main reason that they're auditing you, if it's on the claim, then it's wide open for auditing and to see if it's being used appropriately. And I've participated lately in quite a few TPEs where the modifier that was used in that particular topic wasn't supported in documentation, and it caused an overpayment, and they never even saw it coming. So we want to be really careful that those modifiers are supported in documentation and that we just don't add them because, oh, doc did a procedure and an E&M on the same day, got to throw a 25 on it.
I'm going to really encourage strongly you practice managers out there, supervisors. I know you have a lot going on, but one of your
Jennifer, you're cutting in and out just a little bit there. But I think what you're trying to
symposium there. I hope that we can have people attend this. Christine will be one of the speakers. We have Bertram Lantico. We have Rhonda Buckholz, excuse me. Oh my gosh, my keynote speaker. And we're going to have some great people coming to talk about everything that we deal with, and especially our training our staff, understanding our team members, what they're going through as practice managers, what they need. Yes, we have meetings to go to, but we don't want to be responsible for making them feel like they're overwhelmed. And don't tell them, slap a modifier on. I know some of them out there are being told that, and it could just be a lack of education, a pressure from above. But just make sure that we're not inadvertently being the problem here by not being educated ourselves. So stay educated, come to the symposium. We're here to help you, practice managers, from compliance experts like myself and Christine and others that are here to help you. And so make sure you attend that. You can go to our website, healthcareinspiredllc.com, to find your tickets. And then, of course, we wanted to remind you to stay tuned for more to come. Next week, we're going to be talking to Terry Fletcher. And we're going to talk about another modifier that we want to really focus on and really just understand the split shared. There's some information out there that can be misleading at times to understand the split shared information. And we really want to make sure that we're getting the correct information from the actual correct resources on split shared visits and their intended use.
Right. I think that's another area, Jennifer, that Medicare has some very strong guidelines for split and shared services. But Medicare is not the only payer that reimburses split and shared. And as a matter of fact, the AMA in our CPT books describes split and shared but you have to go back and cross-reference with your specific payers.
Yes.
Never assume that all payers follow Medicare guidance or all payers follow CPT guidance. Remember, this is an art, my friends, and we have to make sure that we're using the correct policy information for the specific payer. Again, I think CMS is probably the big one out there that has some very specific guidance for Medicare beneficiaries. But we need to remember that it's not just Medicare, it's not just Humana, it's not just Blue Cross. That we have a lot of different payers, and different payers have different policies. Not one size doesn't fit all in this matter.
Absolutely. And I know we previously talked with others like Sonal Patel and Pam Vanderbilt on Modifier 25 and 59. So just as a tip or update, this Thursday, I will be live at 6:30 p.m. Central. So we're going to do a special E&M event where we're going to really talk about the evaluation management services and the risk. So it's going to be talking specifically about the risk section of the MDM guidelines and focusing on how the other two elements really complement that and how they're used to really kind of tell the story. We're also going to hit those modifiers because they're E&M related for 25 and 59. We're going to touch on only because it's often misused again as an E&M modifier. We still see it. I see 25s when they shouldn't be there when they're not necessary. So it's huge risk. We're going to talk about the risk to your practice by not knowing the proper way to use these modifiers. So again, it's a huge ROI for your organization to attend this boot camp and to attend the upcoming webinar on Thursday. And so we encourage you to attend that. And I will, of course, be putting the link in the comments here so you can access that. And you can always go to our Eventbrite, of course, link. You can go to all of our events there and see that. So we hope that you will attend and that you will, of course, benefit from that. There will be a CEU offered, so great stuff. And so we'll hopefully see you there. Thank you, Christine, for attending today and being on my guest on the show. I'm so happy to get to talk to you again. And
wait, Jennifer, before you go, can you give me the backstory on that beautiful painting?
Oh, yes. You reminded me of my beautiful picture. So my husband was, kind enough to put my desk together for me while I'm reorganizing my office space. And I was like, what better place than to sit right in front of my favorite picture? So my grandmother passed away in April and we were so close. She I was at her house a lot. We lived next door to each other and my mom was working. My parents were working. My sister and I were taking care of my grandma a lot. She took us on walks. She took us, everywhere. Like we were just kind of inseparable for so long. We played Scrabble and watched Jeopardy. It was just like the funnest childhood. And these were from her house. And so my cousin told me, she said, we want to find out what you want from grandma's house. And I said, well, if nobody claimed those pictures, they are really dear to me. So I have one on this wall. I got two on the other side to kind of complete my living room here. And I just love them. It reminds me of my grandma who I miss and who taught me a lot about integrity and compassion and just kind of, instrumental in who I am today. So this is why I have this in my background.
That's a wonderful story, Jennifer. Thanks for sharing that.
You are welcome. Well, thank you so much, everyone, for joining. And we will see you next week with Terry Fletcher. And we'll have a good week, guys, and stay safe out there.